I'm Nalini Rajamannan. I'm a cardiologist, and I am here at the 22nd International World Congress in Vancouver, and my affiliation is in Wisconsin and Minnesota. I practice at Most Sacred Heart Jesus Cardiology Valvular Institute with a secondary appointment at the Mayo Clinic. And the topic of my presentation is osteocardiology, the role of WnT signaling in atherosclerosis, the go-no-go theory in clinical trials. And I will be discussing the from bench to bedside basic science in our understanding in how calcific aortic stenosis develops, with the initiating events being an atherosclerotic mechanism, and then discussing novel discoveries in the roles of lipoproteins and lipids and genetics, and then how atherosclerosis then over time becomes mineralized and starts to calcify. And the calcification process, which occurs in the heart, is found in a very specific phenotypic pattern in coronary arteries, aortic valves, aorta, mitral annular calcification. So that specific phenotype on the left side of the heart is related to the hemodynamic properties of elevated left ventricular pressures as compared to right-sided pressures. And so the final phenotype is termed osteocardiology, or the role of bone formation in the heart. And then after the review of the basic science, I will be discussing the clinical trials to date in terms of slowing progression of calcification in the aortic valve, what's worked and what's not worked, and try to define a new theorem called the go-no-go theory. In that specific timing to therapy is critical in terms of trying to slow progression. So what's most important with patients who have the predisposition to atherosclerosis and calcification in the heart is to treat all those patients with appropriate lipid-lowering therapies according to the guidelines, antihypertensives and diabetes and exercise, etc., the known traditional risk factors. And then also trying to define specific genetic abnormalities, such as patients who have heterozygous or homozygous familial hypercholesterolemia, or identifying patients who may have familial abnormalities such as congenital calcification, like the Notch mutation. And then after looking at all these hidden determinants and factors, then try to define the point where you take into account now all this novel research and try to sort out the actual go time in terms of initiating therapies, which will be statins in the future, PCSK9 inhibitors, and anti-RNA type medications or antibodies to specific lipoproteins. So there's a lot of excitement in the field. There's a lot of understanding in terms of the hemodynamics and in terms of the biology. And my goal is to outline all the determinants in patients who have calcification to try to slow progression, identify risk factors, and to try to prevent them from needing long-term surgical valve replacement or TAVR in the future.